but you know what I mean. Familiar faces is great. It's lovely for you to join us, and we really feel that so many people have taken the trouble to join us this afternoon. As I said, we're recording the presentation. We won't be recording the discussion though. The discussion will be non-recorded, if that's the right phrase. So join the presentation, as I said. If you could turn your camera and your mic off, that will help us considerably. So this is what you have come to hear and to take part in, and we're very, very glad that you are going to do so. So in addition to our formal equality, diversity, inclusion seminars, of which we've held 2 to date, and we have a 3rd one coming up on the 14th of December. I'm looking at Michelle. Yes, I think the 14th is right. Yes, she's nodding at me. We are putting on also some more informal workshop sessions during the course of the year on a variety of equality, diversity, inclusion issues and challenges. And this is the first one of these. And it's born out of a recognition that whilst disability awareness is important, the social model of disability in particular needs to be fully understood and practically used. All 3 of us that have helped facilitate this presentation, even though it's going to be only me that's going to be presenting it, all 3 of us are experts by experience with a range of disabilities. My name's Julian Harrison, or Jules. I've met quite a few of you. I have lifelong mental illnesses. I have diagnosis of clinical depression, of OCD and anxiety disorder, and also another lifelong thing, I am also autistic. In another vein, I am the equality and diversity consultant that is used by the Centre for Ethnic Health Research, which is why I've come to be here presenting this to you today. I've also got joining me is Sandra Paget, who is a very, very, very important person, erstwhile colleague. So Sandra, do you want to just say a few words of who you are, just to start off? That would be useful.
Thank you, Julian. Yes, my name is Sandra Paget, and I have been the public contributor to this project since it began about, I think, almost 4 years ago. I've done a lot of public patient involvement in research with NIHR, sat on several of their funding panels, and I review for them. I've done lots of things around public patient involvement in research. I also have a mobility impairment, which I've had from very early years. I can't remember ever being without it. And now, as an older person, because it's a progressive, rare neurological, neuromuscular disorder, I now use a wheelchair. But I remember life, I'm 76, I remember life in this country when we didn't have laws surrounding equality with regards to disability. We didn't have the social model of disability. I remember that coming out. And I've been very interested in this equality impact analysis project that is run jointly by the Centre for Ethnic Health and the East Midlands ARC, because I know as a lifelong disabled person that disabled people are not included in this particular area of investigation, and I'd like that to change. I mean, my particular condition doesn't get much funding for research, so that's another aspect of it, not included in the thinking of who shall we research next. So I'm very interested in, I mean, when the pandemic was on, I wanted to try and go along to contribute to the research looking into the vaccination, but I couldn't get to any of the places that I knew people were being asked to go to. So it's just really that you'd been forgotten. You couldn't get there. The transport was awful. You didn't have your own car, which I don't anymore. So that's where I'm coming from with all of this. And I am a disabled person. I'm quite proud of my life and the things I've done with it. And I think the social model of disability is important. I do understand some of the ramifications of it, understand it, but what else is there?
Thank you, Sandra. Thank you, Sandra. That's very succinct and very, very important that people people understand the background, I guess, to that as well. You will see that there are 3 of us, but there's only 2 of us here, and you might be thinking, is there a link between Julian Harrison and Elliot Harrison? And yes, there is. Elliot is my youngest child. They're not able to be here today. They're not very well at the moment. They identify as non-binary with respect to gender, so therefore the visiting that using the pronouns they and them. They also have a similar diagnosis to me, diagnosis of depression, and he has a diagnosis of autism as well. And Elliot has been able to put a lot of insight into the slides and a particular area which I'll draw upon later on as we get through the presentation. So that's all 3 of us. There is a hashtag for today's event. For those of you that are, I was going to say Twitters. I don't know what your tweeters, what you call them now, X's, as their Twitters become X. There is a hashtag. There it is on the screen. There's already some stuff in there. I know. I looked at it before the session. So if you want to make any comments or so forth, please tweet us on that particular hashtag. That would be really, really good. So this is what we're going to look at today. We're going to look at, first of all, what do we mean by disability? I'm going to throw in hopefully some interesting, some quite shocking as well, disability facts and figures. Before we look at the social model of disability, we probably need to look at where it emanated out of and what it came as a result of, which is the medical model of disability and its implications. We'll then look at the social model. There's a number of examples by image. So I'm going to show you some images and how they relate to the social model. We will look at equality impact on the social model of disability. And finally, before we do, we use whatever time we have left to have a bit of a discussion, we will look at the issue of the social model of disability and its implications for research. There will be, at the end of the seminar or sometime in the next couple of days, a handout will be circulated to all of you that have attended. And on that handout will include lots and lots of information from sources that we've used during the course of this presentation, and also some other interesting links that we thought you might find useful. So that is prepared and it's ready to wing itself over to you sometime during the course of this week. So, with all the preliminaries done, let's have a look at this. What actually do we mean by disability? Well, this definition is essentially based on what is legal. For example, what is contained within the Equality Act 2010. And so a person has a disability if they have a physical, mental, sensory, learning and or neurodiverse impairment which has a substantial and long-term adverse effect on that person's ability to carry out normal day-to-day activities. And one of the key words there is "and," because one of the mistakes that lots of people go into is thinking that people potentially only have one disability. Of course, that if you think about it, that's absurd. People can have a combination of different disabilities, and sometimes it's that combination that increases somebody's disenfranchisement, if you like, and marginalization. When we're talking about long-term adverse effect, we're talking about long-term impairments that last or are likely to last for at least 12 months. That's the government's position on it. And the government also says, and it's quite right to say so, that consideration must be given to the full range of disabilities, all the ones I mentioned at the top and any combinations that may come out of that. The Equality Act also mentions 3 specific health conditions that are automatically regarded as disabilities from the point of diagnosis, and they are cancer, HIV, and multiple sclerosis. In addition to the Equality Act, though, the Convention on the Rights of Persons with Disabilities, the CRPD, is an international legal agreement. It exists to protect and promote the human rights of disabled people, so that's also is a very, very important legal executive factor. And I think when you look at the range of disabilities that we have there, one of the important things that we'll come back to time and time again today is that many disabilities are hidden. they're not immediately apparent to people. And that has some important ramifications for, particularly I think, for those of us that do live with hidden disabilities. Just a few disability facts and figures, and I could have chosen thousands of facts and figures here, but I've tried to be a bit succinct. So, about 1 billion people worldwide, so about 15% of the global population have some type of documented disability. In the United Kingdom, that equates to about 14.6 million. That was certainly the case in the 2020-21 financial year. That represents 22% of the total population of the UK. In England, in 2021, a smaller proportion but larger number of people were disabled in comparison to the census of 2011. 52.7% of disabled people are in employment in the UK. So that just about half of disabled people are currently employed in the UK, compared with 81% of non-disabled people. That's a large disproportion that you're talking about here. Indeed, 2021 figures stated that 1 in 5 employers say they will be less likely to hire someone with a disability. This is an interesting fact. The average disabled household faces £975 a month in extra costs. 3 out of 4 disabled people have experienced negative attitudes or behaviour in the last 5 years. Disabled people are more likely to experience health inequalities and are likely to die younger. Indeed, men with mental ill health are likely to die 20 years earlier and women 13 years earlier than their non-disabled peers. So at coming up to 55, if I equate to that statistic, and yes, I have mental ill health, it's quite a sobering thought to think that actually I may be entering the sort of twilight years of my life if I'm due to die, according to that particular statistic. Estimates of COVID-19 mortality risk by disability status for England, produced by the ONS, found that people with disabilities had an elevated risk of death from the disease across all 3 waves of the pandemic. Here's another one I found quite interesting. Nearly half of 25 to 64-year-olds with a learning disability or difficulty in Great Britain have no qualifications whatsoever. And the last one, a little bit quirky, but this is 2018 figures, so I hope there's been some improvement, but over 40% of railway stations in Great Britain do not have step-free access. Please don't get me talking on trying to ensure that access to train journeys for people with hidden disabilities isn't an issue. It is a massive issue on top of those physical constructs that you see there. Now, just a little question for you. What do you think links the following people? And you can put any answers that you think of in the chat. Obviously, they're all disabled people. It would be a bit silly not to have 4 people with a disability at all. But there's something a little bit more specific that links the following people that you can see. Ludwig van Beethoven, composer. Winston Churchill, esteemed statesman and war prime minister. Ruby Wax, obviously, as we all well know from television personalities, and the boxer Tyson Fury. And we're getting some answers and some correct answers coming through. Yes, it all relates here, folks, to mental health. They all had or have a mental illness. You might have thought Beethoven, but the obvious thing with Beethoven, of course, was that he was deaf. He became deaf. But he may have had bipolar disorder, definitely had alcohol use disorder, and almost certainly depression. And this is an interesting thing as well for people like Elliot and myself who are autistic. Beethoven, as well as Mozart, was believed to be autistic. Quite a telling figure. Winston Churchill, believed also to have bipolar disorder. He openly referred to his depression in his writings and in his paintings as well. Ruby Wax, has been open about her battle with clinical depression over many years, and obviously is a prominent mental health campaigner. And Tyson Fury, diagnosed with bipolar disorder in 2017, and he has had some health conditions of depression, anxiety, alcohol addiction, and cocaine abuse. So yeah, they all had mental illness. Here are some words. These are just some problematic words that are often used in relation to disability. There are lots that we could have covered. Some of these are probably more, some of them might be more striking, more direct than others. Others might be a little bit nuanced, but certainly when I was looking at this and I was thinking of my own mental illness, I thought to myself, if I'm using these terminology, do I suffer from depression? Do I suffer from autism? It's a difficult thing it's a difficult context to get your head round. Am I confined to a life with mental illness? Is my mental health a problem? If so, is it a problem to me? Is it a problem to other people? Do I have spells of depression? For someone who's had depression all their life, the thought of having a spell of depression is quite a curious thing. Being a bit more blunt, am I mad? Mad is a word that's often used in relation to mental illness. Am I abnormal? Whatever that might be. And I pose this question to every one of us. What actually does able-bodied really mean? So not saying you can't use these words. Lots of these words, there are numerous websites actually which detail such words and others equally, if not more offensive than some listed here. So a little bit of a website, web internet search for some of these words and the sort of connotations and alternative uses, alternative words instead of these, I think is a very, very good place to start with this. So then, let's get directly into this. What is, first of all, not the social model of disability, but the medical model of disability? And this is a quote called, these quotes coming from the Disability Nottinghamshire organisation. And they said this: the medical model of disability says that people are disabled by their impairments or their differences. Under the medical model, these impairments should be fixed or changed by medical and other treatments, even when the impairment or difference does not cause pain or illness. The medical model looks at what is wrong with the person and not what the person needs. It creates low expectations and leads to people losing independence, choice, and control in their own lives. So said Disability Nottinghamshire. So let's have a look at some of the implications for this. And there are a number of significant ones. So according to the medical model, therefore, it perceives disabled people and their impairments as the problem. We are seen as problematic. The disability itself is the problem. And this can lead to disabled people being stigmatized for their difference. Certainly can be the case with regard to mental illness, for example, but certainly not only mental illness. It focuses directly and indirectly on what is deemed to be normal. And if there is a word in the English language that I would like to change because I don't understand its meaning, it is that word normal, particularly when it comes to health. What is normal health? It's a very funny thing to think about. So the medical model therefore can cause further discrimination, sometimes in new ways. It seeks medical solutions to problems that may not be realistic or achievable. I had a Down syndrome brother. And throughout his very short life, he died because of he wasn't allowed a heart and lung transplant on the NHS. But throughout his life, we were always faced with this: well, what if they find a cure for Down syndrome? What in effect does that mean? What does it visualize? How would my brother become somebody else? It compels, I guess the medical model as well compels disabled people to look at themselves in an effort to change. If I'm the problem, I've got to be doing something about myself to change, to become potentially normal, whatever that is. And the medical model, I think I would agree here, it ignores societal responsibility. It places all the emphasis for change on the disabled person. So, that being said, what is the social model of disability? And Disability Nottinghamshire were equally forthright in terms of coming up with a definition for the social model. They said this: the social model of disability says that disability is caused by the way society is organised, rather than by a person's impairment or difference. It looks at ways of removing barriers that restrict life choices for disabled people. When barriers are removed, disabled people can be independent and equal in society, with choice and control over their lives. So let's think about some of those things. Individuals are disabled by the barriers inflicted in society, not by their impairment. So disabled people developed the social model of disability because the traditional medical model did not explain their personal experience of disability or help to develop more inclusive ways of living. And you've got to remember as well, barriers are not just physical. Attitudes found in society, attitudes based on prejudice or stereotype, also called disableism, also disable people. Other barriers relate to legal, communication, and other discriminatory practices. So, consideration of the social model of disability is particularly important in addressing access and other equality-related disability issues. So, the social model and equality sits hand in hand. It would be incorrect to say that there are only just two models of disability. There are not. There are lots, actually, of models of disability. I'll just give a few examples. There's the biopsychosocial model, which effectively is a synthesis of the medical and social models. There's the human rights model that sees disabled people in terms of the rights they hold rather than the problems they have, as subjects rather than objects. And I guess that's probably more model of disability policy than of disability itself. There is a succinct difference. Others include, and we haven't got time to explain these, that the minority model, the Nordic model, the alternative, cultural models, and so on. So sometimes it can be confusing to keep up to date with new titles and meanings. But I think the more you engage with this particular area of work, of life, the more this begins to make hopefully more sense. And lastly, of course, just to reiterate what I said before, the importance of the United Nations Convention on the Rights of Persons with Disabilities. It's an important legal framework. So let's just look at a few images, I guess, or a few diagrams, infographics that sort of try and pose or to show what the social model is like. Here you have, this is from Nurse Next Door, societal barriers are identified, and they can be, according to Nurse Next Door, environmental, inaccessible infrastructure, lack of service, poor communication; attitudinal, like I mentioned before, negative stereotyping, poor understanding, increased social isolation; and institutional, lack of employment opportunities, non-inclusive legislation, policies and procedures, lack of educational opportunities. So all those are factors that are particularly important and prominent within the social model. This is very short and sharp and succinct. This is from the Royal College of Nursing, actually, and it shows on the left-hand side the medical model. All the arrows there point to the person themselves, the disabled person, as being the problem, whereas the social model looks outwards. There's the disabled person. It's saying, well, what barriers exist within society that prevent me from fulfilling the potential and actually achieving equality of opportunity? So it's quite a succinct model, and sometimes the most simple models are probably the most impactful. Here's an interesting consideration. Again, it's a terminology one: the difference between impairment and disability. And sometimes these words are used interchangeably. However, we believe that it's important to make the distinction. And the distinction really is this: an impairment is an individual's physical, mental, sensory, learning, neurodiverse, or other characteristic. Disability is the name for the social consequence of having an impairment. So people are therefore, according to the social model, disabled in and by society, Disability is a social construct that can be changed and or removed because of the societal responsibility. I went out looking for some pertinent quotes and found so many that it was difficult to choose. But I thought these are quite interesting. This is from the first one. I don't need easy, I just need possible. And Bethany Hamilton was a rising surf star when at the age of 13 she survived a shark attack. Despite only having one arm, she returned to professional surfing and she still is a professional surfer. Robert M. Hensel was born with spina bifida. He's an author, but he's also the Guinness World Record holder. This is incredible. For the longest non-stop wheelie in a wheelchair, covering a total distance of 6.178 miles. Can you imagine that? That's just awe-inspiring. And Robert said this: there is no greater disability in society than the inability to see a person as more. Jimmy Dean, American country music singer, television host, actor, businessman, said this: I can't change the direction of the wind, but I can adjust my sails to always reach my destination. And lastly, abled does not mean enabled. Disabled does not mean less abled. This is from Kang Kijado Nguyen, who's a multidisciplinary photographer, artist, and performer. Really, really good quotes, I thought. Think of the difference between these two phrases. Firstly, people with disabilities, and secondly, disabled people. Now, whilst this is not universally agreed upon, we would suggest that the former adheres to the medical model, i.e. the problem is the disabled person. The latter reflects the social model. That is, the disabling factor is elsewhere in society, in the environment. Think also of the difference between organisations for disabled people and organisations of disabled people, and the associated slogan, nothing about us without us. Just to cement, I guess, the way the social model of disability is used nationally in terms of governance. The UK's National Disability Strategy is based on the social model of disability. When you get your handout, there is a link to the National Disability Strategy, so you can have a look at that at your leisure. The social model is also embraced in the new Disabled People's Manifesto. This is a very new thing. This is a proposed transformational program of action created by disability organisations, focusing on addressing systemic injustice. Now, I'm going to show you now a number of images that all relate to, I suppose, the difference between the medical model and the social model of disability. Here's the first one. The medical model of disability would see the problem here as the disabled person in the wheelchair, whereas the social model would focus on the disabling aspect of a building that is obviously not adequate for people's needs, in this case, the absence of a functioning lift. Physical constructs such as ramps, clearly signed automatic doors, lifts with adequate space for the wheelchair user to move freely and independently are what is required to enable equal access. Sandra was particularly keen for me to mention, and it's totally right to do so, that automatically pushing someone in a wheelchair without permission when they have autonomy of movement is an example of normalism, and it's not a reasonable adjustment. I guess this one was particularly pertinent to me with my brother. But under the social model of disability, adults with Down syndrome would be given the right type and levels of support to enable them to live independently in their own homes. And such support may include dealing with household finances. It may practically mean supporting how to pay bills, what to do when things go wrong in the house, how to shop for healthy foods, how to engage with local authorities and local health and social care services, etc. The medical model Well, that would probably see Down syndrome people as being largely incapable of independent living, requiring instead communal homes and a large degree of institutionalization. We now, of course, have people with Down syndrome that have won Oscars, that are teachers, that are sports people in every area and sphere of life. And the reason they are so is because they have been supported and enabled for their potential to be realized. This is a pertinent one for me, I guess. The social model of disability would seek solutions within the working environment for someone with mental illness in the workplace. That may mean reasonable adjustments, enabling the worker to work more flexible hours with greater time working at home. It may mean putting colleagues on a new mental health first aid course. It may mean more regular informal check-in chats with managers. It could involve the arrangement of timeout rooms and spaces. It would mean addressing pressurizing or stigmatizing attitudes within the workplace. The medical model would probably, not certainly, influence whether a person declares their mental illness at interview from being appointed. It would also mean pushing the worker to take total responsibility for their disability, perhaps even hiding it in an effort not to hinder their working performance and potential. This is a great shot, great image, this. Under or using the social model of disability, people with visual impairments are able to attend and enjoy things like football matches and participate fully if thought was given, in this case, to providing a verbal commentary on the proceedings. Here, Liverpool fan Mike Kearney is assisted by his cousin Steve. Some clubs, including Liverpool, provide a live commentary service for blind and partially sighted supporters. Under the medical model, Mike and thousands like him would have difficulty accessing the ground and certainly following the game. Think of how this also applies to any meetings you organise, focus groups you arrange, and also the product of any literature, material, information as well, publicity, reports, etc., etc. You've got to think disability. You've got to think about disability access. Now, our Elliot was charged with putting something in. He did a lot of thinking with regard to this slide. And they came up with a story that was really important to them, obviously remembering their pronouns. They were participating in a young person's advisory group in the co-production of research centering neurodiverse young people and their increased susceptibility to mental health struggles. They felt it was important to bring up disability ableism in this context, and in doing so was met with a high degree of opposition and skepticism. The leading argument that was given to Elliot was that neurodiverse people are not, and I'm quoting here, disabled enough to be considered disabled. That neurodiverse people can more easily adapt and align themselves to present as neurotypical, as non-disabled. To Elliot, this displayed an incredibly pervasive social narrative that disabled people are solely responsible for implementing their own accommodations, that their struggles are a product of their own neurology, physiology, and that non-disabled people are the societal default, the normal people. And disabled people have designated and should try their hardest to normalize themselves to fit that default. Now, this narrative was so pervasive during these sessions that Elliot went through that it had actually taken control of the very people it was created to oppress, which was quite an interesting thought. Now, what about equality impact and the social model of disability? Well, Sandra and I say a lot of this, particularly when it comes to equality impact, always asking the fundamental question. If I do something a particular way, who may be disadvantaged or excluded? This relates to more than just disability, of course, but is really, really important with regard to disability. Therefore, there's a need to recognise the importance of reasonable adjustments. The need as well to consider all types, forms of disability and specific health disability circumstances. And then asking the questions, are there problems that can be addressed, overcome beforehand? If so, how do I find out what they are? Consider the importance of communication and the need to vary forms of communication to suit people's needs, focusing always on accessibility. Now, doing this and doing it effectively may mean encouraging and incentivizing people who previously couldn't or didn't want to acknowledge that they may be disabled in a legal sense to think that it isn't them that is the problem. It's the environment and society in which they live. And this may be particularly crucial for those with hidden disabilities or whose disability is stigmatized. In this context, what's stigmatized is not the impairment or medical condition, but people's attitudes towards it. Here's just an example of what we're talking about here. So, deciding when and where to have an event for you researchers or service delivers, it doesn't really matter. It applies equally to both. It raises a range of disability considerations. For example, and these are just only some of them. Are all the facilities in the venue accessible to disabled people? Fully accessible, independently accessible? What access issues are particularly important for specific disabilities? Remember, it's certainly not one size fits all, folks. Have I truly considered the range of disabilities when promoting my event? Have I asked fundamental questions beforehand relating to access? Is my approach to this proactive or reactive? Am I demonstrating sufficient encouragement for people who may be wary of stigma to discuss their disability access needs? And probably most fundamentally of all, have I actually asked disabled people what is needed? Just coming towards the end now. Just a few thoughts before we get into a discussion on the social model of disability and research. The previous slides hopefully will have shown how the social model of disability relates to both service delivery and research participation. So, some concluding points. Recognizing and contextualizing the agenda and your research outcome. The agenda we're focusing on here being the disabling aspects of the environment. So whilst recognizing that the intention of research may be something that does address medical issues and improves medical outcomes, using the social model always locates such developments within a broader picture, one particularly related to empowerment. Think as well about the recruitment within diverse disability communities. Note as well the development of disability organisations who have developed because of the social model of disability. Centres for independent or integrated living will be a good example here. Think about accessibility issues and requirements. Accessibility in terms of products, buildings, amenities, communication systems, etc., but also in relation to attitude. Consider as well the issue of technology with regard to access. Technology can certainly enable access, but it may also impose barriers to that access for some. Think about the importance of co-production, genuine co-production, recognizing intersectionality, and keeping that last fundamental question always in mind, asking it and addressing the issue of mitigation. The fundamental question as a reminder being, if I do something a particular way, who may be disadvantaged or excluded? So that's the end of the presentation. I guess we are now thrown open to